TopMedTalk.
Monty Mython here. As we prepare to move into the next phase of the COVID crisis, we're going to be widening our focus here on TopMedTalk. We will continue to deliver COVID-specific programs, but we all have a huge additional responsibility as we try to reboot normal services. So although this piece is not directly related to COVID-19, we believe it's information that is crucial to the bigger task of rebuilding the healthcare system as we learn to adapt and live with this new virus. Thank you to our sponsors and to you, our listeners, for helping us to share this important information.
Welcome to TopMedTalk. This piece is taken from the Perioperative Medicine Shared Interest Group's 2018 annual conference, Measuring, Managing and Minimising Risk, which was held in association with the Australian and New Zealand Society of Geriatric Medicine and the Internal Medicine Society of Australia and New Zealand. Don't forget to check out the show notes on topmedtalk.com for more details. Have a listen.
Now I'd like to welcome Professor Jacqueline close to the podium. Jacqueline's trained as a geriatrician at the King's Hospital in London, came to Sydney in 2006 and now has a extensive clinical and academic career. Her academic career is with Neuroscience Research Australia, and most of her clinical work is in Prince of Wales Hospital. Her clinical practice is centred around geriatric support to orthopaedic and surgical specialties, and has a particular interest in falls and fractures. And that interest has, funneled into her being the co-chair of the Australian and New Zealand hip fracture registry. Thank you, Jacqueline.
Good morning, everybody. I'm aware you've been sitting for nearly an hour, so stand up for 30 seconds. As a geriatrician, I'm worried about pressure injury and gastrointestinal motility. All right, that'll do. Now, the first thing I should do is declare that I see geriatricians as having no role in the operating theatre. This is the most I will ever do, is bring the surgeon or the anaesthetist a cup of tea. Now, surgeons and geriatricians have worked together for decades. In the 60s and 70s in the United Kingdom, there was an enlightened orthopaedic surgeon who realised that actually after he'd operated on his hip fracture patients, that leaving them lying in bed was bed rest, essentially, for the rehabilitation for the coffin. So geriatricians and orthopaedic surgeons have worked together for many, many decades. Geriatricians and other surgical specialties less well developed at this point in time. And geriatricians working with anaesthetists, I think we're all still trying to find the happy medium as to where and how the roles are delineated. So I'm going to start by talking a little bit about orthogeriatrics. Don't assume that it's all done and dusted. It absolutely isn't. What we do know, though, in terms of the literature, and again, decades of literature telling us that orthogeriatrics, so geriatricians working with surgeons, is associated with a reduction in complications, length of stay, fewer deaths, and better functional outcomes for the individuals. Whether orthogeriatrics delivers more to patients who haven't got a hip fracture but other low trauma fractures, that's less well established, but most orthogeriatricians will look after people with other low trauma fractures. The United Kingdom way ahead in terms of the work they've done on hip fracture. This is an external evaluation of the impact of the hip fracture registry of the United Kingdom associated with the standards, the guidelines, and a best practice tariff. And it's looking at reduction in mortality. So before the introduction of the hip fracture registry, you had a percentage annual change in mortality of a reduction in annual mortality of minus 1.8%. Since the introduction, one of these things, isn't it? Since the introduction, you've had a greater reduction in mortality. But just be careful about these figures, 7.4%. We did some work in New South Wales, and our 30-day mortality in 2014 for hip fracture was 7.2%. So just be careful doing cross-country comparisons. Again, a paper published last year from the United Kingdom, essentially showing that the more hours a hospital trust funds for orthogeriatrics, the lower the mortality. That doesn't mean to say it's the geriatrician, but there is something about those hospitals that is reducing mortality. So in this country, of course, we have in fact, Australia and New Zealand, we have a binational guideline, we have binational standards, and we have a binational registry. And the registry's been going now, so we published our third annual report just last month. Just under 10,000 patients now entered, so the number of hospitals increases on an annual basis, which is great. There's a feel for the population, so mean age of 84, over 2/3 are female. Most come from home, but it still means 29% come from residential aged care. 41% have cognitive impairment prior to admission to hospital. 55% use an assistive device. I'm going to suggest they're probably frail. So despite the fact that 40-something% are cognitively impaired, this graph shows you how often we are actually assessing somebody's cognition prior to surgical intervention. So the yellow up here, these are hospitals, and most of the hospitals chose to be named. These are the hospitals that clearly are doing good things. This is Sunshine Coast, that's Concord, Princess Alexandra. Clearly processes in place there to objectively assess cognition prior to surgery. Hospitals down here perhaps not as good at assessing cognition. We also do it by state, so that's how we perform at a state level in terms of who's assessing cognition prior to surgery. I'll let you draw your own conclusions. Nerve block. So from a patient perspective, pain management is really important, and there is a huge amount of variability at the moment in terms of who is being administered nerve blocks. So the whole idea of nerve blocks, temporary relief of pain, and hope to minimise the amount of systemic opiate analgesic agents we administer. And again, you'll see, so this is nerve blocks both before and in theatre, nerve blocks before theatre, and again, huge amount of variation across the country. This always makes me laugh. This is type of anaesthesia. Again, so yellow is general anaesthesia. Some hospitals, including my own, the vast majority get a general anaesthetic. Others, it's varied. Does that matter? Well, at this point in time, I'm not sure it does matter. We don't have the answers really as to whether one is better than the other, but there is clearly variability. But of course, we will know the answer in a couple of years' time because we've got the Regain trial going on, looking to try and answer once and for all whether regional is better than general anaesthesia. So the Regain trial is recruiting, I think it's 1,600 individuals randomised either to regional or general anaesthesia, with the primary outcome at 60 days either death or not able to walk 10 metres. Will it answer the question? I'm not sure. Time to surgery, so this does matter, again, to patients. And again, so on the left-hand side here, you'll see the yellow are the people who are operated on within 48 hours of admission to hospital. Now, I think 48 hours is very generous. I wouldn't want to wait 48 hours, and I suspect most of you wouldn't want to wait 48 hours. But there are some hospitals down here really struggling to get patients even 50% operated on within 48 hours. And that includes Liverpool, which is my co-chair's hospital. And I know from his perspective, he's used this data to get extra operating lists at Liverpool Hospital. So the whole idea is not to hit people around the head, but to use the data to actually drive change. And again, we provide the data by state this year as well. So lots of issues in terms of access to theatre. So that's what we should be using this data for, is actually to drive change and develop better outcomes for these people. Hip attack. So this may change how we view hip fractures in terms of getting access to theatre. So this is P.J. Devereux's paper from 2014, looking at the whole idea of getting people to theatres within 6 hours, people with hip fracture to theatres within 6 hours. So the primary endpoint here, and this is a pilot, the primary endpoint is death or serious complication. It's not statistically significant, but it sends out a signal that it probably is beneficial. So the hip attack trial is ongoing. They're still recruiting. I think they'll be recruiting up till about 2020. They're trying to recruit 3,000 individuals. So again, that's a watch this space. If that's positive and does show significant differences in terms of access to theatres, that will throw the cat amongst the pigeons in terms of prioritising people for theatres. Another thing to remember when I showed you the nature of this population is many of these people are towards the end of their lives, and there's often debate as should we or shouldn't we operate, and sometimes the surgery is actually an appropriate palliative procedure to alleviate pain. But this was a study just looking to see people from nursing homes, severely demented, what happened to them and whether they were operated on or not. And they were looking at mortality, but pain, antipsychotic use, physical restraint and pressure ulcers. And the reality is, if you had surgery, you are less likely to be in pain. So that's a good outcome, even at the end of life. And you're less likely to have a pressure injury, but you're more likely to be physically restrained. Now, this is an American study. I hope we wouldn't see the same in this country, but the Royal Commission may tell us otherwise. But the other thing about this population is a lot of them are dead at 6 months. And it does beg the question, so yes, it's fine to operate on these people to alleviate pain and make it easier to nurse them, but how many of them were we actually planning for a dignified death? Well, actually, of those that survived to 6 months, only 1% had a do not hospitalise order at 6 months. So they were all potentially going to be shipped back to the emergency department at that stage in their lives. So venturing beyond orthogeriatrics, why would we do it? Will we add value? Which patients should we be seeing? Which specialties? And what will success look like? Geriatric patients are very definitely not defined by age, partially defined by comorbidity, and I think frailty is probably where most of us feel it's the best way in terms of us identifying which populations we should be involved with. And you have heard time and time again during this conference that frailty matters. It's associated with bad outcomes for older people. So geriatricians really aren't interested in this top end here. We really are interested in these people who teeter on the brink of functional independence. This is work from Christina Norris's PhD, which is still ongoing, but it's really looking, so this is 300 surgical patients, elective and emergency, and looking at the impact of age, comorbidity and frailty on a number of different outcomes. And you can see quite clearly frailty is a better predictor of any complication, need for rehabilitation and length of stay. It doesn't seem to have any effect really in terms of readmission rate, but it is important and it's probably good. It is probably the right population for us to be looking at. But we really need to move beyond just screening and saying frailty is important. We really need to be looking intervention. What are we going to do with this population that is going to change their trajectory? Well, Cochrane, so there's a Cochrane review from 2018 looking at comprehensive geriatric assessment and does it work? Well, yes, it appears to work in the hip fracture population, but there really isn't enough evidence at this point in time to say that we can add value with comprehensive geriatric assessment beyond the orthogeriatric setting. Unfortunately, that particular Cochrane review didn't include this paper, which was published in the BGS in 2017. Very nice, randomised control trial by Jagdeep Desi's group at St Thomas's, really looking at comprehensive geriatric assessment in advance of standard pre- and perioperative care. So a comprehensive assessment, tailored intervention, liaising with the GP, liaising with the anaesthetist, liaising with the surgeon, having a plan in place, including a discharge plan in place prior to admission to hospital. So I would argue that that is anticipatory, preemptive, comprehensive care. And did it work? Yes. So its primary endpoint was length of stay. It did reduce length of stay, but it reduced a number of other complications, including delirium, which many of us feel very strongly about. Something else we feel very strongly about. So, as you know, Donald Trump had his annual medical check this year, and you'll be pleased to hear, as a result of scoring 30 out of 30, so he was able to recognise a lion, a rhinoceros, and a camel, but he's now a certified genius. Don't let that put you off the test, though. The mocker is a good test. Again, just to emphasise that delirium is important. So this is a study of 566, I think it was, individuals undergoing elective surgery, predominantly abdominal and orthopaedic elective surgery. You can see the complication rates down here, not terribly high for most of the usual complications that we would look for and measure. 24% developed a delirium. How often, when you consent somebody for surgery, are you consenting them and saying, 1 in 4 of you will develop a delirium, and delirium kills? It is associated with many, many bad outcomes. It's associated with more complications. It's associated with longer length of stay. It's associated with an increased risk of institutionalization. So can we actually alter that trajectory? And the answer is yes. There is evidence out there that says that by intervening, we can alter the cumulative incidence of delirium. So this is a really simple intervention. No drugs involved whatsoever. It's 30 minutes of extra nursing time per day after surgery, where somebody actually talks to the patient, tells them where they are, tells them what's going on in the world, make sure they clean their teeth, give them some orofacial exercises to do, and gets them up out of bed. And it reduces the incidence of delirium. It is simple. Comprehensive geriatric assessment reduces the incidence of delirium. There are multi-component non-pharmacological interventions that reduce the risk of delirium, including 2 that were in surgical areas as well. So there is evidence out there that we don't need drugs to reduce the incidence of delirium. And in fact, there's a Cochrane review out just last month looking at delirium in non-intensive care unit patients. And of those 39 trials, 32 are actually in surgical patients. And when you look to see what potentially works to prevent delirium in hospital, that's the bottom line. It's the multi-component intervention that works. Cholinesterase inhibitors, antipsychotics, particularly haloperidol, don't work. There is, sadly, some evidence for olanzapine. That was a paper many years ago in a journal called Psychosomatic, but I haven't read it. And look, depth of anaesthesia seems to make a difference. We haven't talked much about depth of anaesthesia at this conference. So which patients should we be looking at? Well, we've had a little look ourselves to see where we're going. So this is very definitely Christina Norris's work. So we've undertaken an observational cohort study looking to see which patients we should be looking after. Delivered the shared care model, so COPS, and let me assure you that the surgeons chose the title of COPS, not the geriatricians. That would have been a very bad start for us. And we're still evaluating this model. So I'll just give you some preliminary data today. So there is Christina, and she's at this conference, and she's still writing a PhD up, and it better be finished by this time next year. I'm a very nice supervisor. So we first of all looked at 303 patients, a mix of elective and emergency. We focused on people aged 75 and above. Most surgical patients, so these are not orthopaedic patients, most live in the community. Most are 59% mobilised independently. 14% cognitively impaired. They're different to the orthopaedic hip fracture population. So it's important to remember that not everybody under the care of a surgeon actually undergoes surgery. So that's very relevant when we're trying to work out what model of care we provide. So for general surgery, only 30% actually undergo surgery. Different in plastics. Median length of stay, 4 days. These people are in and out pretty quickly, and most people go directly home. So most people don't actually require rehabilitation. Complication rates. The complication rates are pretty high. They're higher in the emergency patients. That's not a surprise. This is important. No significant difference in complications between those who undergo and don't undergo surgery. So people coming in with small bowel obstruction, large bowel obstruction that is managed conservatively, they still run into problems. And in terms of the common complications, it'll come as no surprise. Delirium is the commonest complication, but they do run into problems with cardiovascular and renal complications as well. This is Christina's heat map. And it was really just to try and give us a feel for across the surgical specialties. So if you're trying to decide where are you going to go into, you really want to go into the specialties where you think you have a chance of making a difference. And the areas probably are acute surgery. So we define it by looking at functional status, cognitive impairment, complications. So the ones probably where we should be looking at are vascular surgery, and you'll hear more about that in the next session. Plastic surgery, so we've just started to go into plastics now, and acute surgery very definitely does feel like the right place to be as well. But in terms of screening, only 50%, less than 50% are screened for cognitive impairment, not many screened for malnutrition, 50% see a physiotherapist, so lots of room potentially across all surgical specialties to improve care. I'm not saying everybody needs to see a physiotherapist, but I'm suggesting that is probably an underrepresentation of how many should. So we delivered our model, people 75 and above. We chose on a pragmatic basis, partly informed by the data, partly informed by the fact that acute surgeons wanted a shared care model. So we opted to go down the route of acute and general surgery, colorectal, upper GI and oncological surgery. And you'll have heard from Michael Cox yesterday that Nepean was our partner in this. And the model of care, so shared care is different to a consult service. Shared care is joint responsibility, joint accountability, shared decision-making, and it absolutely has to come from the top. The consultants need to demonstrate the behaviours that they expect of their juniors. So it is very much about our patient, not my patient. So that's a shift often in the way we practice. And we did indeed use the clinical frailty scale. So again, you've seen this multiple times. We've used it as a screening tool to identify which of the population of people coming in under the acutely under the general surgeons should we be undertaking comprehensive geriatric assessment. So we've used it as a screening tool. It doesn't tell us how to intervene. It tells us which population we are going to look at. We also, however, did do care coordination in terms of case conferences on a twice-weekly basis for everybody, and all the patients also got increased physiotherapy input. There are our Nepean partners. You won't recognise Michael. I can see him in the audience. He's got much less hair at the moment. So in total, over that 16-month period, we have looked between the two hospitals at just under 800. It's a pity we didn't go to 800, isn't it? But anyway, nice round number. We've looked at 799 patients, and we're in the process of going through what the outcome's going to look like. And we're looking at outcomes from a number of different perspectives. So the clinical outcomes, did it actually make a difference for the patients and the clinical teams, length of stay and cost of care? So the bottom line at the moment is it does look like it is working. We are seeing reductions in many complications, so acute kidney injury, cardiovascular type side effects, cardiac arrhythmias, pace calls, dependency on transfers for day 3. So that early mobilisation with the physios going in twice a day to see these people seems to be working. So this is Prince of Wales data. Length of stay, we're reducing length of stay by 0.6 of a day. It's not an awful lot. So that's a little bit disappointing. Nepean's reduction length of stay is greater. Falls are reduced across the whole surgical ward, so that's good. Documentation, this is Nepean data. So one of the benefits of actually documenting is that you actually have a much better feel for the true complexity of your cases, and that is also linked to funding because your NWOW is increased. So you get better reimbursement when you have got a better picture of the true complexity of the patients that you're actually seeing. So geriatricians on the whole tend to be pretty good at documenting. But Nepean is seeing the same picture as us in terms of reduction in complications as well. We have asked both patients and the staff their views on what it's been like working with the COP service over time. So this is just Prince of Wales data. Nepean are just starting to do their patient and staff experiences now. So blue means strongly agree, red means agree, neither agree or disagree, and green is disagree. So on the whole, patients seem to like the service, so they felt involved in their care, informed about their care, and that the staff actually understood what their needs were. And then in terms of here, this is not all allied health and nursing. The majority of respondees to the staff survey are actually the surgeons. and actually they seemed to like the service as well. And they were asked to provide 3 words that described the COP service. Now, I'm very disappointed that that's the size of the response for knowledgeable. So I'm going to conclude. I think that orthopaedic care is well established, but there's still lots of room for improvement across Australia and New Zealand at this point in time. I think the evidence for the role of geriatric medicine in other surgical specialties is still emerging, and we absolutely must evaluate every time we develop new models of care and put in place new services. Geriatric medicine needs to be clear who its target population is, and we do need to think about how we more effectively work with our anaesthetic colleagues, particularly if we're moving to looking at elective surgical patients. It would be wrong to over-service these individuals or duplicate assessments. We need to be smart about how we work together into the future. And do we need large RCTs? I'm actually not sure. Thank you very much.
TopMedTalk.
Nick Majerison here. Thanks for downloading TopMedTalk. TopMedTalk is the broadcasting arm of EBPOM, Evidence-Based Perioperative Medicine. EBPOM has been advocating perioperative medicine for many years now, using the traditional conference circuit, where people have attended meetings from all over the world and heard some of the latest information. However, in the face of the COVID crisis, EBPOM took a bold decision. We've transposed the entire conferencing experience into an online experience. Carbon-friendly conferencing. The latest information, the latest talks, the hottest experts, the most incisive analysis, and even the socialising. We've got it all covered as EBPOM goes virtual. Hot on the heels of the huge success of EBPOM 2020 live from London, we're now headed towards EBPOM Chicago. Come aboard and be part of one of the most exciting developments in medicine since the stethoscope. EBPOM Chicago. Get yourself to ebpom.org now and guarantee yourself a place at one of the most exciting conferences in the world.